There we go. Again, my name is John Ogunlade from Washington University in St. Louis, and thank you to the course directors for putting on another amazing course this year. Always look forward to meeting with the faculty and our participants. So without further ado, we'll just get into it. I think when you're doing a transforaminal approach, it's important to understand some very important considerations. As we've already seen, there's different ways to get through the foramen and to the foramen to get extraforaminal, and there's going to be different approaches that you use based on your pathology. And rather than sit here and tell you that this approach is good for that and this approach, I'm going to show you some cases and hopefully get you thinking about what approach you would use. And we'll see if you agree with me or not, and maybe I'm right, maybe I'm wrong, but we'll do this kind of as a group activity. But in general, there's a trans SAP, which Ahmad showed. You can ream and use usually crown tip reamers to remove a lot of bone quickly. And then there's a transforaminal approach where you're really going for a soft disc herniation, usually foraminal, like Peter showed. In the foraminal disc herniation, usually as soon as you land into the foraminal zone, you're already at the pathology, and you can resect that really quickly and then spend 40 minutes looking to make sure you got everything. And then with an extraforaminal approach, you could do a transpars or extraforaminal kind of transforaminal kind of hybrid approach, which Hofstetter and Meng showed really well. So we got a great demonstration of all these different approaches. And again, we'll let Javier show us how he does the biportal technique. But some considerations, level of pathology, that's important. As we've seen previously, we'll get into that, sorry. Axial zone of herniation is important to kind of understand where the disc herniation is. And then we'll talk about the sagittal migration of that herniation, which may also alter your approach. And then last, which is a very important thing, is how much foraminal stenosis you have. So for a transforaminal approach, I think Meng gave this talk last year, and it really just shows, for interlaminar at 5'1", it's really hard to argue to do anything else other than an interlaminar approach and anything that's in the canal. But when you have a foraminal pathology, you have to really look at that foramen, look at the morphology of the foramen, because sometimes the iliac crest can get in the way and make it very hard to get to your pathology. However, as you go from cranial to caudal, the size of the foramen typically goes down. And this paper that came out at the end of last year actually shows that, looking over 700 different patients, as you start from cranial to caudal, the AP diameter of that foramen starts to get smaller. But then more importantly, the height of the disc space peaks at L304. And so when you think about an L304 pathology, typically that's going to be your largest height of your foramen. And as you start to move cranial and caudal, it will shrink a little bit, and L5S1 being the smallest. So it's something to keep as a consideration as you think about what your pathology level is and what actual procedure you're going to offer for that surgery. And then where is your disc herniation? That's also another important thing to consider. For central zone herniation, you may have to remove some of the SAP so that you can get more medial and get your scope a little bit more midline. If it's a extraforaminal zone herniation, you may not need to do any bony resection at all. And if you do, it might be very little, like removing some of the pars, depending on where your herniation is. So again, this is another consideration as you think about what surgical approach you're going to use for a transforaminal approach. I think another thing that we don't really, think about often is how far migrated is that disc herniation. So for a far migrated disc herniation, it's really hard to get something that's very, very cranially migrated or very, very caudally migrated. So I would say, think about this in zones, and think about the zones that are furthest away from the disc space, which are the very highly migrated disc herniations, as something that you may have to remove some bone. So in a way, you're thinking this is a highly migrated disc herniation. It's maybe a tight foramen, and now I have to remove some bone to not just get access, but to be able to actually reach up and grab the fragment of that disc herniation. And that's a good segue to looking at the actual foramen. So when you look at the foramen, there's different grades of these, of the size of the foramen, and the way in which the foramen is actually collapsed matters. And what we've seen in the paper, which I'll go over, and Christoph already went through as well, is, when there's vertical foraminal stenosis, those patients, they do okay with endoscopic spine surgery, and they do well as far as, improving pain at 3 months and in 6 months. But those patients don't have the same recovery as patients who have normal height foramen or just soft pathology within the disc space. So it's important to understand not just it's vertical foraminal stenosis, but what's causing that compression of that nerve root? Because that may change overall your desire to do an endoscopic approach versus maybe be more aggressive and do maybe a trans-SAP approach to, decompress the foramen. So let's go over some case examples. That's why we're here. So this case, it's, L405 disc herniation. You can see the disc is really collapsed. You can see that, let's see. You can see here that the, you can't see that. Let's see, just go. There we go. So you can see here that the facet is showing a little bit of facet fluid signal here. You can see there's some lateral recess stenosis. This is a subarticular herniation. And, though this disc height is, kind of collapsed, you can also see that the SAP is starting to ride into that nerve root. So you could do a transforaminal approach and simply just use a kind of shallow dock, which I think is also a way of saying extraforaminal, and drill out the SAP. Or you could use the trifines and do a trans-SAP approach and quickly take down some of this SAP and help reduce your surgical time. So for me, there's not much of a disc herniation here in the sagittal plane, mid-sagittal line. So for this very low migrated disc herniation, I would do a trans-SAP approach. For a disc herniation like this, you can now look at this at, again, L405. This patient has more of a, I'm not sure if you can see this cursor. This patient has more of a, foraminal, maybe even extraforaminal disc herniation. You can see that the morphology of the facet joints are really vertically oriented, or I should say sagittally oriented. And so doing a trans-SAP approach here might cause you to slip, and really your pathology is outside of the frame. And so this one should be pretty straightforward, and that could be an extraforaminal approach. Now, the question is, would you do a, trans-pars, or would you do an extraforaminal kind of, transforaminal approach? And I think either one is a correct answer, but for me, the trans-pars is a technique that, though I've seen Hofstetter do it, I haven't quite picked it up myself yet. So that's something that I might add to my armamentarium. So this is a case with the L304 central disc herniation. You can see that it has a low migration, inferior low migration, and there's no real foraminal stenosis. The height of that foramen is wide open. It's about 20 millimeters in a cranial diameter, in the sagittal plane. And there's a massive, large pericentral disc herniation. So I would say that, this is a very good for a transforaminal approach. You can easily get into that foramen. You can easily resect that disc herniation. That's a soft disc. You might have to, separate some of the planes to really identify that disc herniation, but this is a case that's good. And you can see this was a revision case or adjacent segment from a previous open laminectomy. So in this next case at L405, you can see that there's, grade 3 foraminal stenosis, really not a lot of disc migration. And this is a subarticular disc here on the patient's left side. For some reason, this thing's not working. All right. But if you look at the axial on the left side of the screen, you can see this kind of, I guess it confirms that this is
I think point is taken.
Approach. Yeah, sorry, trans-SAP approach. So the point's made. Anyway, we'll move on. So here at L304, you can see this is, again, another subarticular disc herniation, but this one's a little bit different, right? It's in that left subarticular zone, but it also is highly migrated. You can see that that disc herniation migrates up underneath the SAP. So it's not enough to simply get, and if you look at the actual neuroforamen, it's at L304, it's got a little bit of disc pathology at the bottom, but that exiting nerve root is free, and it's really like more of a 1A foraminal stenosis as opposed to, significant vertical foraminal height loss. So for me, I still think that this is a trans-SAP approach because we need to reach cranially to get that extruded fragment that's gone up the canal that's superiorly and highly migrated. So at L405 for this case, you can see that there's, again, some grade 2 foraminal stenosis, another superiorly very high migrated disc, and there's a little bit of a spondy there. But as we've talked about before, doing transforaminal approaches really does not destabilize that segment. And I would argue that this would be a trans SAP approach as well, so that you can really reach up and grab that extruded disc fragment. This is a L405 central disc herniation with an inferior high migration. So it's not a very super high migration. It's really just a little bit migrated down almost to the midline of that vertebral body, going caudally, and not really a lot of foraminal stenosis. You might have to remove some of the top of the pedicle. This would be a case that I would do transforaminally, and essentially, remove some of the top of the pedicle, kind of maybe even shallow dock, and then reach around the corner and grab that disc herniation. Moving on, this L203 central disc herniation has a little bit of an inferior low migration, and it's a grade 0 stenosis. So again, I think this is great for a transforaminal approach. So hopefully it's starting to drive down the way in which I think about these procedures or these cases, and how I identify what's the best way to treat these patients. In this L405 subarticular disc, there's no migration, and you can see that it's really mostly just a subarticular disc herniation. This is great for a trans-SAP approach. I gave the answer away. So L405 paracentral disc, and again, low migration, no foraminal stenosis, and again, easy for a transforaminal approach. In this last case, we'll go over, it wouldn't be a great endoscopic talk if I didn't have any video, so we'll go over this case a little bit more detail. You can see this is at L203. It's an extraforaminal disc herniation. Hopefully this works. You can kind of outline and see that here on the left side of the screen, there's a extraforaminal disc herniation pushing that exiting root dorsally. So Christoph, you talked about doing a trans-pars approach for this. I think that's a great approach, but personally, I think you can also do just an extraforaminal approach for this, and that's exactly what we did, and I'll show you how we did it. So the targeting is pretty similar to that of doing a traditional transforaminal approach. The only thing that's different here is I'm shallow docking, because again, that nerve root's being pushed dorsally, and I want to kind of work my way into the foramen. And if you notice in that preoperative imaging, there was also some lateral recess stenosis. So we work our way into the foramen, we drill out some of the SAP, and then once we get there, I always take that shot just because that's how I was trained. But once we get there, you will see that this video doesn't play. All right, there we go. I don't think I could fast forward, but just for brevity, I won't bore you with narration, but essentially you get there, as you saw in the lab, you'll expose your landmarks and identify your SAP, and this is what we're doing now, widening our foramen, doing a foraminotomy. And just for kind of understanding where we are, we're on the patient's left side, so the left of the screen is cranial and the right of the screen is caudal. And right now we're just exposing the traversing nerve root. So we now just did a transforaminal foraminotomy and a lateral recess decompression, exposed the traversing nerve root. And we follow that traversing nerve root to our exiting nerve root in the axilla. And this is important because sometimes you get this disc herniation that looks like it's a nerve. This disc herniation is underneath the nerve, and we know that based on our preoperative images, but how can you be confident what's nerve and what's disc? So allowing yourself to find that traversing nerve root and then to see that axilla between the traversing and the exiting nerve root helps you identify clearly what's disc pathology and what is actual nerve root and what's neuropathology or neuro elements. And so in a small piecemeal fashion, and this is not sped up, we're simply just working underneath that disc herniation after developing that, underneath that exiting nerve root after developing that plane, and we're gonna slowly resect this disc herniation however it wants to come out in a piecemeal fashion. If it's en bloc, that's great. And really the goal is to simply just put less little pressure on that exiting DRG that's already irritated and resect this fragment. And the length of this video is 2 minutes, and you saw that we spent maybe 20 to 30 seconds talking about drilling and exposure, so the discectomy only really takes, at most, once you get there, a minute to a minute and a half.
Hey John, do you have some tricks to identify, because it can be very confusing to see, what is PLL that goes out there versus nerve root? What are your tricks? Do you try to identify the nerve root first, or do you just follow the the analyst, or how do you get that?
No, so yeah, I actually follow the fat. That's one of the speed pros that I've heard before from Sanjay actually. And one of the things that I do is I first find that traversing nerve root, find the plane between that nerve root and the disc space, follow that all the way up to the exiting root, and then find that exiting root going up and over that disc herniation. Then from there, in the first part of the video, I went and I separated the plane between that disc herniation and the actual root. And now you can see the root's completely free. There's nothing in. I'm doing a final check to make sure there's no leftover disc herniation, and that's the end of the case. So I would be remiss if I didn't, give a very brief shout out to the ESRG. I think it's an amazing thing that we are able to do as a group, and I think we're constantly evolving the way we do research collaboratively, which I'm happy and proud to be a part of that. And more recently, we published this paper, in which Christoph already went over, but I'll just say that what we saw was, patients who have vertical foraminal stenosis, specifically people who have grade 3 stenosis on the Lee classification, or even patients who have vertical foraminal stenosis from bony stenosis in the up-down plane. Those patients, they do okay, but they don't do as great as the patients who just have normal foraminal stenosis from disc pathology or from the AP diameter. So very good paper. I would definitely recommend you guys read it. And then last but not least, for those of you who are interested in joining the movement of ISURF, right, I think it's important to understand what education can do for you as a group. We're a collaborative group of surgeons who love to work together to do research and to further spinal endoscopy, just not in the United States, but globally. So I would highly recommend that you join us and ride the wave. And here are my references.